we'll be ready to go. Just a couple of reminders. We do record our seminars and we put those up on the HSMC website. So if you're interested, have a look back at our back catalogue and see what other seminars we've had in this series. Martin, I think we've got everyone who said they were joining, is that right?
Yes.
There's a couple more just joining in here at the moment. Yeah, okay. Well, let's get started. So thank you everyone for joining us today. This is one of our regular seminars at the Health Services Management Centre at Birmingham. This year we've been running seminars with speakers who have got connections with HSMC, whether that's been staff, whether they've done research with us. And we've had a couple of people who are visiting professors with us, and that's our speaker today. So let me just introduce our speaker, and then we'll get into the seminar properly. So we're delighted to welcome Professor John McDonough. John is Professor of Public Health Practice in the Department of Health Policy and Management, so very similar to HSMC in some ways, and he's based at the Harvard School of Public Health in Boston. John has a PhD in public health by background, a master's in public administration, so is very familiar, I guess, to the work that we do. It's very similar. John's career to date has just been a fascinating journey through health policy, health politics, and health practice. So just to give you a few highlights, he has been a member of the Massachusetts House of Representatives in the 80s and 90s. He's also been the executive director of Healthcare for All in Massachusetts, promoting universal healthcare. And then in the around 2008, 2009, 10, he was the senior advisor for national health reform for the US Senate committee. And that was one of the committees that enabled the Affordable Care Act, or sometimes known as the Obamacare. So he spans research, policy, and practice in such a fantastic way. So we thought that we should really make sure we try and get him to one of our seminars this year. And he's going to speak today on some work that he's undertaking at the moment, some research. And the title sort of speaks for itself, Healthcare and Neoliberalism, comparing the United States and Great Britain. So John's going to speak for about 30 minutes, and then I'm going to just offer a few reflections on the UK, mainly England, and then we'll open it up for discussion. So without further ado, I'm going to pass over to John. Just to say one reminder, I think everybody is muted already, so thank you for that. But do put your comments, questions in the chat option, and we'll use those as the basis for our questions later on. So no more introductions from me, and over to you, John. And thank you very much for joining us today.
It's a pleasure and honor to be here with you, Mark. Can everybody hear me okay? Am I coming through? Excellent. Thank you. So it's a real honor to be here with you all. I'm a big fan of the NHS, and I've watched the UK system from afar for a long time, done some work with it over the years from my position at Harvard, and I really appreciate this opportunity to do some reflection on the similarities and differences in the pathways followed by the UK and Britain over the past 45 years. I'm going to talk mostly about the United States and what's been happening here, and the troubling direction our health system has been following for some period of time, and assessing where we are right now, and hoping that that offers a counterpoint in terms of your consideration. I was a practicing politician in the Massachusetts legislature for 13 years. Sometimes I refer to myself as a politician in recovery. It's a lifelong affliction, and you can never really get it out of your system. So it's just something that you deal with. And I spent several years in DC working on the writing and passage of the Affordable Care Act, and have paid very, very close attention to that since then. So I have lots of different perspectives and things to offer, but I'll just start. I have about 30 slides, and I won't linger on them. I'll move kind of rapidly so we can stay within the half hour. And I hope everybody can see them here right now. And let's just dig right in. And so let me get going. Here we go. So I'll start just with a little bit of an anecdote. This is an article I wrote for Politico magazine in the spring of 2021. And it was a double-barreled article in the sense that it was about a conservative idea that was adopted by progressives. It was created for Republicans, adopted by Democrats, became enshrined in federal law as part of the Affordable Care Act. And it was called the individual mandate. So in our Obamacare law, we required that all Americans who could afford to buy health insurance were legally obligated to do so, or else they pay a penalty on their taxes. And it was an idea that once Democrats adopted it and tried to make it policy, became the public enemy number one for the conservative movement. It wasn't developed by Stuart Butler, whose picture is on the right, but he was the key popularizer of it in the late 80s from his perch at a conservative policy think and do tank in Washington, D.C. called the Heritage Foundation, which was started in 1973 to create a conservative balance to our establishment, Brookings Institute, which they regarded as much more on the left. And Stewart made that idea real, and it got traction, was adopted by significant Republican figures. And then when it became center of President Obama's health reform agenda, Republicans, led by a new grassroots movement called the Tea Party, picked that out as public enemy number one. And so Stewart went from being kind of the toast of the conservative town to being public enemy number one among his own political home. And so interesting story. So if you're interested, you can get it for free on Politico. And it's really an exploration. Stewart came from the UK. He was born and raised somewhere between Manchester and Liverpool in that area. And he actually has a younger brother. They both came over to the US in the 70s. Stewart stayed, his brother Eamon came back and started the Adam Smith Institute out of Edinburgh, and he's still active in it. But Stewart is over in the U.S., and so it's the story of Stewart and his intellectual journey and what happened when he got in the middle of high stakes, polarized health policy in the United States. And it's also underneath it all a little bit of a profile and a story of neoliberalism in this period. So just invite you to it. It's a longish piece for a magazine article, and you might just find it helpful in thinking about back and forth. It's interesting that Stewart came over and became such a leading voice with his background of the NHS. He never really thought much about health when he was in the UK, and then when he came to the United States, all of a sudden he had to. When he got his first job and went to work at the Heritage Foundation, he had to buy health insurance for himself, and has some funny stories to tell about that. Anyway, so just a little personal thing. If you're interested in this and you want to know some more, I would just call this to your attention. So here's how I look at a lot of the framing here. So this is just a little framing piece. We have a political historian at Yale University named Stephen Skowronek, who's developed his own form of what's sometimes called as regime theory. When we think of political history in the US, people instinctively think of, well, a presidential term of office. So Lyndon Johnson, Ronald Reagan, George W. Bush, whatever. And Skowronek says, no, it's larger intellectual periods when there are dominant ideas that transcend somebody's administration and even transcend partisan turnovers back and forth. And he suggests that we had 5 presidents who really kind of carved out new intellectual, political theory, policy, terrain, knowingly or unknowingly, that they were starting a new era that lasted well beyond their term of office. And so I would just say we focus a lot on 2 eras, the 2 most recent ones. The first one, Franklin Roosevelt, the New Deal, the Keynesian era that started in the midst of the US Great Depression. And he took office in 1933. And if people understood that the conservative Republican free market era was over, and Roosevelt started a muscular and aggressive era of regulation and expansion and higher taxes. And that era actually went on for about 48 years. And it came to an end in late 1980, early 1981, when Ronald Reagan became president of the United States. And he really came out of the newly energized conservative free market movement. And he didn't know it, and we didn't know it, but his regime has lasted for at least 40 years. The big question mark we have right now, kind of like the question mark people had in 1934 and in 1981, 82, 83, is, are we at the start of something new? You don't know at the time. It takes several years to figure it out. I mean, I was 27 years old when Ronald Reagan got elected president. I was convinced, like many, many other people, that he would be a one-term president. He'd last 4 years and he would be out. And instead, he lasted longer, replaced by George H.W. Bush. And his era went on, even with Democratic presidents, Bill Clinton and Barack Obama. There are, as Skowronek suggests, there's 4 types of presidents. There are the initiators, in this case, FDR and Ronald Reagan, of the 2 most recent eras. There are the presidents from the same party who follow them and want to make their own mark, expand the terrain of what's possible, but are also very much trying to keep the good times rolling, keep the intellectual movement happening that the initiator created. So for FDR, that was Harry Truman, John F. Kennedy, Lyndon Johnson. For Ronald Reagan, that was George H.W. Bush and his son, George W. Bush. And in each of those eras, you have presidents from the other party who get elected, who have maybe the hubris, the idea that they're going to turn the apple cart upside down and change things. And what they find is that in spite of their best efforts, the times won't permit them to create their own revolution. So in the FDR era, that was Dwight Eisenhower, Richard Nixon, Gerald Ford. And in the Reagan era, that was Bill Clinton and Barack Obama. And then we have the 4th category. This is actually my favorite, the end of the roaders, the people who preside over the collapse of an intellectual regime. It was Herbert Hoover's collapse in the Great Depression that set the stage for FDR. It was Jimmy Carter, who had a disastrous presidency on many levels in the late 70s, who lost to Ronald Reagan. And then we have the big question mark of Donald Trump. Did Donald Trump represent the collapse and the end of the new neoliberal era in the United States? And that's still a question. Interesting, across history, the 5 end of the road presidents who represented the end of an era were all one-term wonders. They lasted 4 years and then they were out. Anyway, so was the November 3rd, 2020 election the end of an era? I would say, I think most people would say it's too early to tell. There's a lot of signs in both directions, and we'll talk about some of those. Here are just a few choice quotes that I selected from the last 40-something years. Ronald Reagan, Margaret Thatcher, a controversial quote that she made, that she initially said there's just no such thing, it's only individuals, and then with criticism, she was forced to add families to the mix. Bill Clinton was a Democrat. He wasn't a supporter of Ronald Reagan, but he very much exemplified the effort to try to remake neoliberalism in democratic clothing during his era, and famously said the era of big government is over. Going all the way up to 2006, and this was on the death of Milton Friedman. Larry Summers, White House Democratic presidential advisor, made a famous statement. Any honest Democrat will admit that we are all Friedmanites now, meaning followers of the Friedman philosophy. I would not suggest that that is commonly accepted wisdom, but it was a statement of a leading, powerful, influential economic voice. And then James Medlock is a pseudonym for someone who's anonymous, but he kind of exemplified the question in his Twitter, where he said that the era of big government is over, saying that in 2021. Anyway, a little bit of that. So, okay. So what do we mean by the free market neoliberal era? Different names for it in the US context: Reaganomics, supply side, conservative, free market, libertarian, neoliberal. The people who use the word neoliberal for the most part are the opponents of this regime. People on the conservative side never call themselves the name neoliberal. The only people who did for some time were Milton Friedman and Friedrich Hayek, two of the intellectual drivers of this revolution. Interesting, Hayek was born in Austria, grew up in Austria, moved to England, and then moved to the United States. So kind of Stuart Butler maybe followed in his steps a little bit. And Milton Friedman and he were very much partners in the 40s and 50s. Milton Friedman became the leading voice for this new movement, although there were many, many other people. Some of the pioneers, definitely Margaret Thatcher, Deng Xiaoping, both in 1979, Ronald Reagan in 1981. You could add to the list before all of them, Augusto Pinochet in Chile, who deliberately, consciously adopted the guidance of what is sometimes referred to as the Chicago Boys in the mid-1970s in remaking Chile's economy in ways that were kind of a disaster. But what are the rules of the road? What do we mean by this in terms of real life? So I have 8 rules of the road here about the role of government in society that very much are drawn from Milton Friedman's writings, other people as well, but give you a pretty good idea. I won't read them through because you can look at them all, but I'll be making reference to all of these as we go through it, because I've got a fair amount of data to share with you as we go forward here. And so how does all of this relate to the US healthcare system? And so we see, that neoliberalism and the free market movement didn't just happen in 1981 with Reagan's inauguration. It started, you can see its roots going back to the 1930s, 40s, getting bigger in the 50s, coming into its own in the 60s, and really taking off in the 70s. So we see the growth well before 81, but the major trends that we've seen really taking off in the late 70s and into the 80s are a huge expansion of the for-profit footprint across the US health sector, hospitals, group practices, the nursing home industry, home healthcare, all of these moving away from more traditional either nonprofit or government ownership and instead going into the for-profit space to get access to capital. As in the larger economy, we have seen the growth in the financialization of the US healthcare sector. These days, particularly involving the phenomena known as private equity. Private equity is exploding in the US healthcare system. It has been for the past decade at least, started really in a noticeable way after 2000. The last decade, I'll have some data I will show you. Growing, widening income disparities among Americans and within earners in the healthcare workforce. A privatization of government services. Our big program in the United States that is government owned and run is our Medicare program for senior citizens and many disabled. Today, we have a choice. You can stay within the government-run part of Medicare, or you can enroll in a private, what's called Medicare Advantage health plan. It is now expected in a way that has shocked just about everybody that within 2 years, a majority of Medicare enrollees will be in the Medicare program in a private, mostly for-profit health plan. Deregulation on lots of different levels. Deliberate, conscious, purposeful non-enforcement of antitrust and monopoly. Milton Friedman used to say that the exception to his list of commandments would be anti-monopoly. Government has to enforce and prevent monopoly. He changed on that in the 60s, and he came to a different attitude. He said, no, monopoly is bad, but government intervention in it is a cure worse than the disease. So we should just let the free market sort it all out. And so a sharp divide. And then in the late 70s, but very much into the 80s, the dismantling of the anti-monopoly regulatory apparatus in the United States. A couple of famous lines in our movie Wall Street in 1987. Michael Douglas plays the bad guy, Gordon Gekko, who famously says to a crowd of workers fighting the takeover, the for-profit takeover of their plant, greed is good. And then I would recommend a book if you're really interested in digging more deeply into this. Elizabeth Rosenthal is a physician, trained at Harvard Medical School, practiced medicine for a long time, and then became a healthcare journalist covering the medical sector for the New York Times. She's now the head of the Kaiser News Service, which is an indispensable source of information on the US health system, put out 5 days a week. Her book in 2017 called An American Sickness really puts it together. She has 10 rules of the dysfunctional US healthcare medical marketplace, one of which I put here: prices will rise to whatever the market will bear. So these are some of the realities of the US healthcare system, and they've all become so much more pronounced since the 1980s. Here's a chart. Right now I'm going to show you a bunch of charts that try to illustrate what I'm talking about in terms of the transformation. This shows US health spending as a proportion of our gross domestic product going back to 1980 from US government and OECD data. And what you can see is that the US is the top line, the dark line. And what's interesting is it goes all the way back to 1980. And if you go back all the way on the left to 1980, what you can see is that the US was the largest spender, and we were very much in the pack. We were part of this bunch of multicolored spaghetti strands and in there. And it was in the early 1980s for the first time that the US really broke away from the pack, starting probably about 1982, 83 or so. And since then, it's just been up, up and away. Some leveling off periods in the 90s and in the 19-teens, the 2000 teens. But for the most part, it's been a dramatic differentiation between the US and all the other systems. Notice all the other systems go up, but just nothing compared to the US. And I would teach this and show this in lectures to exec ed audiences, students, and others who were interested. And I would almost always, someone would ask the question and say, what the heck happened in the 1980s that made us break away? And for a long time, I gave a number of hypotheses. It might have been, the growth of public programs, lots of different explanations. But as I got more deeply into it, I have become convinced that while there are numerous factors involved here, the one that matters the most is the corporatization, the growth of the for-profit footprint and presence and accompanying deregulation on the US government side. Our wonderful health policy foundation in New York City, the Commonwealth Fund, has been putting out these apples to apples comparisons of US versus other countries. This is their sixth that they've done since the early 2000s. And you can see the UK second from the right over there, but understand that every time they've done this, the 10 of the 11 countries shift around. Some go up, some go down, back and forth, because they're all as you could see in the last slide, they're all pretty much bunched together in so many ways. But the one consistency of the 6 times that they've put out this study, they started with only 4 nations, now they're up to 11. But the one consistency is every time they've done it, on the overall ranking, the United States comes in dead last every single time. And I remind my students, many of whom get up every morning and kneel next to their bed and say a prayer to the shrine of the perpetual Canadian single-payer system, I have to remind them that according to this study, Canada only looks good in comparison to the United States. Many different ways to skin this cat, to go forward. So the first chart here, you could make an argument, say, well, yeah, we spend the most, but we get such great value from it. And so it's the value question. So if we were spending this amount and we had world-class results, outcomes, measures that showed tremendous value, we could have a wonderful debate about that. But instead, we spend the most, and we are by far the most dramatic underperformer in the world. Okay, let me just go. I'm going to go through a few things for you, and I'm going to go relatively quickly so we have maximum time. But so this is life expectancy at birth, also from the Commonwealth Fund, and you can see, the U.S. never a great performer, going back to early 1980s on life expectancy at birth, but starting in the early 90s, again, we broke away this time in the other direction down, so that we are now on life expectancy from the rest of the OECD, an incredible outlier in the opposite direction. This is a little bit more updated, and you can see going up now through 2021. So about 5 of the last 7 years, life expectancy in the US has gone down. Something that we thought, wow, we're beyond that. We're beyond those things happening. Clearly, all nations took a dip, or most nations, not all, most nations took a dip in the COVID-19 crisis, none to the extent that we saw here in the United States. So it's just, it's again, one more indication of the dilemma that we face in the US. Here's just another look at the same piece. This is male, female, and overall. And you can just see this, this extraordinary decline that we are seeing. Here's another way. One of the things that defenders of the US healthcare will say frequently is they'll say, yeah, well, we're not doing good overall, but we've made some whopping improvements in particular sectors. And one of the things they will always mention is we're doing great on heart disease mortality. And you have to take that into account. So here's a chart that shows, yeah, we're doing better, but not compared to Ireland, the UK, Canada, Australia, others, and so forth. So just kind of, keeping that in mind. And here's data just from one state. And this is from a book that got a lot of attention in the US in 2020. Angus Deacon and Ann Case, Deaths of Despair, which looked at middle-aged men and women, and for the most part, mostly white. And this is data from the state of Kentucky, looking at the ages, 45 to 54. And what they demonstrate is just this extraordinary divergence, looking at the early 90s to today, between the health outcomes for people who have a college education down here below and people who have not completed their baccalaureate degree up here, or, and also haven't completed high school. Just extraordinary divergence. Here's another way also from Deaton and Case, and this looks at birth cohorts. And so the left chart is the growing death rate among folks with less than a baccalaureate, and the right side is the baccalaureate. Here are the leading causes of death in the United States under age 40, very recent data. Of note here, I point to firearm deaths, both from homicides and suicides. We are a country, because of the growing strength of libertarian ideology, that has created an absolutist interpretation of the Second Amendment of our Constitution to declare an almost untouchable right of citizens to bear arms. Both in many states right now, it is concealed weapons and it is open carry as well. States like Texas, conservative red states, have just deregulated. And Massachusetts, where I come from, is recognized as having the strictest gun laws of any of the 50 states. And you look at the mortality rates, and it's just an extraordinary differential in terms of lower suicide rate, lower homicide rate, lower gun accident and injury rates across the board. And nobody elsewhere around the country seems to care, because the right to carry arms has become just absolute. Here's another population health outcome that we like to draw attention to, or I like to anyway: overweight and obesity prevalence. So again, go back to the early to mid 1970s and where we were making progress. And over these past 40 years, the rate of, and it's overweight and obesity. It's now, this goes up through 2017. You bring it up today, it's about 73%. So the line continues to grow here. And of course, this is directly connected to all kinds of chronic disease, including research has shown many different types of cancer as well, and mortality, so forth. It's just, and it's going on all around the world. You folks are clearly seeing it in England as well. And you see Mexico up here. Interesting, the data from Mexico is interesting because within the past 10 years, they put in a national hefty tax on sugar-sweetened beverages that actually has had some significant impact. Here's another look at, here's obesity and diabetes, which of course we know run together. Top obesity, bottom diabetes, and 1994. Dark is worse, as you probably figured out. Here's 94, here's 2000, here's 2015. Amazing concurrence between these. The CDC has a chart where they rapidly show just year by year the growth and the change in the color context of the country. And it usually leaves audiences gasping, but I saved that for you today. This gives you a good idea of it. Also, we've seen, again, starting in a little bit before the 1980s, but growing dramatically since then, growing economic inequality. That is we have 4 different lines here. Women in the labor market, percent in union, percent in manufacturing. Income inequality is kind of the starred line that starts here below 0 in the 1950s and stays pretty steady It doesn't really cross the line of where it was in the early 50s until the 1980s. And then we see an extraordinary growth in income inequality in the United States, which is, Milton Friedman was very clear in his readings and his talks. He said, in societies, there's a trade-off. There's a trade-off between inequality or equality and economic freedom. And basically what he said in his typical black and white fashion, because everything with Milton Friedman was black and white, he said, you have to choose. Do you want to have a more equal society, or do you want to have a society with more economic freedom? And you have to understand that there's a trade-off. You can't have both. And he said, I vote for economic freedom, as did his entire movement, which is what has been mostly government policy in the United States, is expanding economic freedom and not paying attention really in a serious way until our friend from France, Thomas Piketty, began to put this out. Here's a chart that I liked just because it puts UK and France and the US in terms of the relative wealth of the top 1% in net worth. And you can see we've gone from number 3 among this trio to number 1. And it's even worse if you include the top 10%, the top 5%, the top 10%, whatever. This is wealth, and this shows the changes. Again, this is just since the 1990s in terms of the wealthiest, and you can see what's happened. Particularly look at the purple line, the bottom 90%, and their share of the relative wealth in the United States. And this was not accidental. This didn't happen kind of, oops, we didn't really know that. This was purposeful, intentional federal government policy with people who were well aware of what they were doing, didn't brag about it or talk about it, just kept it. And it was really Thomas Piketty and the Occupy Wall Street of 2011 that really helped to change this. Here's a little bit from Piketty. And this is between 1980 and 2014, and the pre-tax income growth in the United States, even among the top 0.01%, you can see the incredible differentiation versus the bottom 50%. Racial wealth disparities are also a big part of this in terms of the differential between the light blue line and the growth in wealth of whites versus African Americans and Latinos. And this is just a little favorite piece. I'll stop and I'll go about 4 more minutes and I'll be done. But this is from a friend of mine, John Komlos, formerly of University of Munich. He's been in the United States now for a while. He put out this study in 2004 that gives the data that shows that for most of the 20th century, the American men and women, native born, meaning the children of immigrants, but not counting immigrants themselves, were the tallest in the world among leading advanced nations and the slimmest. And we have now gone from being mediocre in terms of height among advanced nations and absolutely being the heaviest, the greatest BMI, body mass index, and so forth. Just extraordinary change in population health. You go back to World War II, and there's absolute clear evidence that US males and females were the tallest and the slimmest. And now we are among the shorter and by far the heaviest. Just a little bit on the for-profit sector. And this is looking at the pivotal period between the 70s into the 80s and 90s. And so what you can see here just with this chart above is the change in terms of the rate of conversions for hospitals from nonprofit to for-profit status, both individual, but mostly starting after the 80s, all the growth came in for-profit hospital chains, a big, big part of this now. And this shows a little bit about investor-owned beds, again, going from 1975 just to 1984. And if you look at just, for example, the investor-owned hospitals from 380 to 880, the investor-owned beds from 51,000 to 113,000, something was clearly let loose and moved forward starting in this period. Here's just a little staggering, very rapid transformation in terms of what we refer to as home health agencies, home care, taking care of people after hospitalization or people with chronic illness. And the key thing I'll ask you to look at, the line is proprietary home health agencies in our Medicare program for seniors and disabled, going from 145 agencies, and by the way, most of these are chains, they're not single episode, to 628 of these chains in 1982. And then you look beyond into 1984 and you can see 756. Just keeping going. This is growth in investor-owned healthcare systems. Again, this pivotal years between the late 70s into the 80s, investor-owned hospital systems from 414 to 878. And then nonprofit hospitals managed by investor-owned systems. We still call them nonprofits, but they are effectively governed and run by for-profit operations. So again, about a doubling over a very rapidly short period of time, when we saw that spurt for the first time in terms of US and GDP. Tremendous growth in physicians and administrators in administrators as opposed to physicians. And then here's looking at it from the health insurance side. And this is an examination late last decade, but among US health insurance companies, the percent of markets that are super concentrated, meaning almost no competition, and highly concentrated, meaning very limited, is about 90% of the US insurance market. This is a sign of monopoly, antitrust regulators asleep at the wheel. Okay, last couple of slides here. In the early 80s, we called it the LBO, the leveraged buyout. And this is the same as what happens with private equity, some differences, but you can see the growth through the late 80s of the number of leveraged buyouts and the dollar value from 1.4 billion in 1979 to 77 billion in 1988. And then in the late 80s, the American public started to learn more about this and get appalled. There was a famous leveraged buyout of RJR Nabisco that led to a book by a couple of Wall Street Journal journalists, and the title was "Barbarians at the Gates," and that kind of gave you everything you wanted to know about it. And so there was a revulsion, and Congress started to act against leveraged buyouts. And they kind of went into abeyance during most of the 90s and reemerged in the 90s, but really in the 2000s under President George W. Bush. And here you can see, but it was a slow start in the early 2000s in healthcare, much more aggressive elsewhere in the economy. But it started to grow in the 2000s. And this is the story over the last decade of the growth of private equity buyouts in the healthcare sector. And this is everywhere. This is hospitals, nursing homes, dental practices, home care agencies, hospices, substance abuse and eating disorder outfits, autism, rehabilitation, practices, medical ambulances and emergency air transport, just every sector of the US. And here's just one more chart for you. And this is another way. This goes through starting at 2000, the amount invested in healthcare by private equity capital. And you can see there's different forms for how it's done. Growth and expansion, secondary buyout, a direct buyout of the operation, lots of these things. But a big piece, I did some checking and I saw in the UK that private equity has also been growing by leaps and bounds in your sector. And I would just warn you about private equity in healthcare, because I think, that I have a book I'll share with you. It's called Ethically Challenged, which just came out in April of this year. And it is really an attempt, the first one that I've seen, to create an overview of the impact of private equity in all corners of the US healthcare system. People have been looking for metaphors to describe private equity. Some call them vampires, some call them pirates, different kinds of things. I've come up with my own preferred metaphor. I like to refer to private equity in the healthcare system as the termites in our system. In this respect, they're not out to get us. They don't wish us ill. They just want to eat our houses. And that's what they do. They invade our houses everywhere they can, every crack and crevice. And they make a big difference, and for the most part, not a very positive one. So just a few concluding thoughts. What explains these terrible outcomes? To me, the outcome, the cause that stands out the most to me in arena after arena when you examine it is the change in the political economy of healthcare, from one that was saying government has to be in charge here in some way, to one which says, no, we need to release the magic of the marketplace. We are starting to see in the Biden administration some significant changes in the government and in society. We're seeing a whole new renewed effort for the first time in 40 years on antitrust and anti-monopoly, led by our Federal Trade Commission. And interestingly, last November, the president of the United States Chamber of Commerce, in a public statement that you can get on the website, declared war on our Federal Trade Commission, said they were going to war to try to stop them from slowing down the forward march of antitrust, of monopoly and antitrust. We're seeing growing awareness of the impact of private equity across society and very much in the healthcare space. We're starting to see the resurgence of unionization and worker power, and we're seeing lots of consideration and discussion, but it's too early to say. And I will stop there. And sorry I went on too long, but happy to have the opportunity to share all this with you.
John, thank you so much. That was fascinating. I think we're all. Oh, I think your screen's gone a little funny. If you stop sharing, then
let me stop sharing. I'm sorry.
Work. Yeah, no. So thanks. A fascinating insight, taking us through 40 years in 40 minutes. I think is a fantastic achievement there. So thank you. Martin, could you call up my slides? I'm just going to offer a few reflections on what's been happening, I should say, in England.
Good, thank you.
As opposed to the whole of Great Britain. That was in the title. So I'm going to focus my, if you could just move to the next slide, Martin, thank you. So I'm going to draw on some work that I've been doing with some colleagues on corporatization. And I acknowledge the work here of Rod Schaaf, Russell Mannion, who I think is on the call, and some other colleagues, Pauline Allen, etc. So this paper's sort of still in progress, but we wanted to share just some general thoughts. So a couple of points about sort of where we've come from. So it's sort of reiterating some of the things that John's been speaking about really here. What's often been called the Washington Consensus, so picking up on Butler and others, privatizing public providers. In the NHS, of course, that was always politically toxic. So that was probably ruled out quite early on. But as a result of that, there's been a whole series of other neoliberal initiatives. It didn't just stop there. So the key one perhaps would be the 30-year experiment we've had with marketization, started in April 91. And arguably, it sort of ended this July with the arrival of integrated care systems, ICSs, across the 42 ICSs across England, which was really Simon Stevens' kind of policy as chief executive of the NHS to address the inefficiencies and fragmentation of the market. And of course, that was ironic because he was heavily involved in United Healthcare for many years and was Tony Blair's health advisor. So his fingerprints are heavily on the second half of this period we're talking about. There's been a massive increase of private provision of publicly funded services. And I'm particularly thinking here in England of mental health services. So perhaps not so much the big building type places we think of hospitals, but mental health care particularly. And then much more pervasively making organizations and management much more business-like. And I'll come on to that in a minute. So part of all of this was what we teach our students, of course, about new public management. But what we've been seeing in the last few years, I think, is perhaps what some people have called maybe a post-new public management, whereby the public organizations, and I'm particularly thinking about the NHS here, have become commercial in themselves. They've become much more entrepreneurial, and that's partly because they've been given much more, or many of them have been given much more autonomy. And under the 2012 Act, they were allowed to increase their non-NHS revenue up to 50%. And some work that we published with the Health Foundation suggested 9% of NHS trust income comes from non-NHS sources. So that might be services for other organizations such as local government. It might be clinical trials. It might be retail. It might be land sales, other joint ventures with other clinical providers. So 9% has sort of crept into the NHS. And of course, some places, the Royal Marsden Hospital in London, specialist in cancer care, is tops in the country, which is in the high 20% of their income comes from non-NHS sources. Next slide, please. Thanks. So how would we sort of see this in practice? Well, some of these things are probably quite familiar with to you, but using the kind of Precker and Harding approach, 4 criteria, really. First of all, it's about specifying the commodity. So we need to be much more clear about way in which activity and outcomes are measured, financed, but there are some obvious limits in healthcare. Oliver Williamson talked about this, of just being unable to be knowing about every single possibility. And we think of the shift now towards much more multi-morbidity, integrated care, much more difficult to commodify that. Increasingly, much more exclusive ownership. And by that, I mean the separation out of kind of a unitary approach into what was called in the market terms the purchaser-provider split, and perhaps reached its zenith with the Foundation Trust Programme, giving much more individual autonomy to organisations. Some studies that I did about 10 years ago found that many of those FTs did not use that autonomy. They were either much more socialised into centralisation, still looking upwards rather than downwards, but they were much more aware of the risk, and many of those so-called entrepreneurial managers were risk averse. We've had an issue, or neoliberalism would suggest that you'd have much more emphasis on prices, but we've kind of avoided that. So in some ways, we haven't had competition in the market, but really for the market. So people or organizations compete or have competed for particular groups of services. Competition by price hasn't happened, except we have used or adopted the kind of DRG approach of a standard tariff, a menu, if you like. The challenge, of course, is that the reimbursement rates given by government have been falling. And so in some cases, the reimbursement by government hasn't always covered the cost. accelerating the shift towards much more commercial solutions that I mentioned earlier, the 9%. And yet we still have issues around productions, and by that we mean the emphasis on regulation, much more over regulation by government, and also that centrally and then locally the introduction of a much more of a kind of profit motive, and not necessarily profit, but at least surplus maximization, and trying to address some of the shortfalls in other areas of income. And then just my final slide, please, Martin. Thank you. So what have we seen? What's our kind of what's an assessment here in 2022? Well, for a good 10 years or so, we've been seeing the emergence of networks, which in some ways has been a bottom-up response to try and address some of the shortfalls of the neoliberal approach. So the whole issue of relationality, the way in which networks would operate, particularly between commissioner and the provider, suggested much more of a negotiated order rather than necessarily following the market signals. And that's partly because often those were quite weak. NHS hospitals, by and large, generally don't go out of business. Even places that had been put out to the private sector, and I'm thinking of Hinchinbrook Hospital in Cambridgeshire, have had very soft landings by comparison, really. And that's partly because centralisation still remains. There's been a strong hand on the tiller. We see that with our new government, just in the last couple of weeks still, much more emphasis on intervention. But there's a lot of ambiguity locally for managers and executives. And again, I point to kind of commercialisation. Are they supposed to be public servants, or are they looking much more at commercial solutions? And that's partly because, and I think this perhaps addresses one of the questions that came up in the chat, how do we allow that? John's presented a massive strong evidence there. And arguably we could say that the kind of political accountability we think of normally to Parliament for public expenditure has been challenged to some extent by the way in which many of those individuals before, maybe during, and certainly afterwards, have been co-opted often by the private equity firms that they've been managing. So it's not just a central local issue. We've got a central local and now an external market intervention, and not market of the NHS type. So there's been a whole series of unintended dysfunctional consequences. The NHS had to introduce a whole set of workarounds, trying to find ways that we can, the policy might remain of a market, but how do we get that around that? Integrated care, the Vanguard scheme that was from the 5-year forward view that Simon Stevens introduced. We've still seen rising transaction costs, and of course that takes up a huge amount, as John pointed out, with administrative costs. And of course we've got a whole series of system failures. As well as that, my final point is really one of the biggest impacts, I think, is alternative frames, alternative ways of thinking about these sorts of challenges have often been excluded or downplayed. So the emphasis on neoliberalism has been to the neglect of thinking about that. And I think that's where researchers have got a very good role to play, particularly in advising policymakers as well. So excuse the very quick run through, but it offers hopefully a little counterpoint to the ideas that John was talking about. So Martin, if you could stop sharing that, and I will open up to the floor for questions. Now, I think one of the ways we might do this, we've had a whole slew of questions, comments, and observations. We've got quite a lot coming through. I think perhaps if we take them in a set of batches, really. So I think most of these are directed towards John. I haven't been keeping up as I've been speaking for the last few minutes. If we can just take them in order, John. There's some around the politics. One specific one about Lyndon Johnson and whether that was a keep it going president, and then also about Biden, but Biden's second term, but also the extent of the initiatives that Biden has been undertaking. You were pointing perhaps to some signs of optimism. Would that be fair to say?
Yeah, so just around Lyndon Johnson. So it was Franklin Roosevelt's unrealized ambition to address a national health system, and he could never do it with the other challenges that he faced, and so it was always on the drawing board and never got off it. But President Harry Truman, who succeeded him, took his idea and made it a big legislative effort in Congress. And it was our first national big-time clash over the direction of our healthcare system and the Red Scare of anti-communism, the intense opposition of our American Medical Association, of the new growing commercial insurance industry, and others were able to thwart it. And the conclusion at that point was that it was too ambitious in the United States to try to do it all at once. And so probably the smart thing, and this was in the early 1950s, would be to just go for senior citizens. And that took 13 to 15 years in 1965. But so Lyndon Johnson really realized the FDR Truman ambition in scaled down form. It was an important, major political accomplishment and a continuation of the trend of broadening the social safety net to include health insurance, albeit just for the elderly at the start. Mm-hmm. And then for Biden, no one knows if he's running again. I sure don't know. But if he chooses not to run, there will be a line of about 36 leading Democrats are ready to take his place and run. It will be a heavy load of people, including, we assume, the vice president. But so I don't think I think, that the directions that we're talking about that I was discussing are really they're not contentious within the Democratic structure. There are some people who stand up for private equity, but for the most part, there I think is a lot of consensus of a need for a change in direction here. And I mentioned some of those directions in my final slide, and I think those are going to continue. And there's also, interestingly, on the Republican side, there are some people who have kind of broken from the neoliberal consensus. Milton Friedman wrote one of the most famous op-eds in American history in September 1970 in the New York Times Magazine. And in that op-ed, he declared that the sole purpose of the for-profit corporation is return on equity to shareholders and nothing else. All this stuff about obligations to workers, communities, customers, the environment, just as communism, socialism, hippiedom, it must be abandoned and trampled. And his ideas, he didn't invent it, but he really popularized it, became boiled down to 3 letters, MSV, maximizing shareholder value. And it was a perspective that took broad, deep hold in corporate America and also in the business schools, by the way, too. This was the new Bible that people were taught when they went to business school. Today, leading Republican politicians, I mentioned some names, Marco Rubio from Florida, these are US senators, Tom Cotton from Arkansas, Josh Hawley from Missouri, and others, very hard right conservative people, will say openly and explicitly that they reject Friedman's notion that the only obligation of the corporation is to its shareholder. And so there's a growing firmament that say, no, that was just Milton Friedman acting out, and we don't believe that anymore. And that's just one of many, many examples that we have. So there's change in the wind. There's change in the ideas. How far it will go, how broad it will go, we don't know at this point. But we do have the Biden administration going head on the anti-monopoly front.
And of course, you've got your midterm elections coming up shortly, so you'll that might shape the next or the final 2 years of this presidency. Yeah. John, you picked up on a couple of points around international comparisons, and certainly British politicians had prided themselves on the Commonwealth Fund. They'd often use that table when we were first. We've interestingly slipped to fourth now. But you're right, the consistent point is the bottom of the table, bottom of the league. One interesting observation I think that comes out, James and Martin have pointed this out, that generally speaking, the UK has been quite good at health system factors up until outcomes. So I think if you look at the table, we've fallen down on the outcomes. So we might have a good system, but as we know, the social determinants are much stronger. What's the kind of the climate of debate around that shift towards outcomes, particularly among healthcare providers, in terms of sort of population health management, really, I suppose?
I would just note a New York Times article about a year ago. I think I could get the exact date for you if people wanted it, but an article basically saying that population health outcomes in the UK have declined substantially. That obesity rates are growing noticeably and faster than elsewhere around the world, and that there seems to be, while the system itself seems to be performing at a better than average level for sure, that it's the population health outcomes. And if you look at the United States, of our list of terribles in that chart, we're terrible on everything except for process of care, which deals with the medical care process itself. And so, in the United States, what you have for the defenders of the system who would, trash me up and down the hallway for what I just presented to all of you, is that, I ignore and I miss all the wonderful things going on in our medical care establishment, as exemplified in that chart by that there. And then, and then it becomes a question of, okay, so what's most important to you? I regard the purpose of a health system as better population health, broadly speaking. And clearly we're missing the ball in that, but some people comfort themselves by saying, but we provide such exceptional medical care for people who can get through the door and afford it.
Yeah, well, once you've got through the door, once you've got the access.
And once you're already sick, as opposed to the stuff that is preventable that you shouldn't be in there for in the first place. And we do a terrible job at that.
Right. Because just picking up on that point, Dermot makes a comment about the separation of mortality into amenable and preventable causes.
Yes, totally.
And those that might help the input of with the input of health services. So yeah, trying to pick out what can be done by the health system. And was it McGuinness talked about? Is it about 15% is due to of health improvement is due to medical care?
Yeah, and we are right now in the United States, and I think a lot of it is directly because of Obamacare, the Affordable Care Act. We are now more focused on population health than I think we've ever been in the history of our system, our medical care system. But it's interesting because there's two kinds of population health in the United States. There is kind of public health population health, and there's medical system population health. So in traditional public health, you care about the health of a community. So, you're paying attention to all of Liverpool and understanding, and it's done usually by the government authorities who are trying to get a sense of what are the top issues, how do we address them. but really the growth in population health focus in the United States is focused on covered lives. So United Healthcare, for example, is very much in our Medicare Advantage program. They are paid on a capitated basis for it, and they are focused on improving the population health of their enrollees. And they don't care about people who are not in their circle at all. And perhaps asthma is a good example. So if you're a United Healthcare and you're covering kids in school, you want to make sure that the kids have their breathing devices to take care of asthma attacks when they happen. If you're the public health organization, you want to pay attention to the school environment. What are the triggers in there? But United doesn't care about that because they only care about their own kids. So there's two kinds of population health. But, it's encouraging because it used to be, these firms didn't care at all about the health of their population to prevent them. And with capitation, they have an economic incentive. But there's so much noise going on in other parts of the system. But it is a big deal, a much bigger deal now than it was. But some extent, it's still not got the appropriate right focus to get the kind of change that we need to see happen to improve our deplorable population health outcomes.
You mentioned, you focused a little bit on obesity there, and Martin notes that there's some countries, Korea, Spain, where that's falling. And it's interesting, you mentioned the Mexican sugar tax, because that's often been used. Our new government is reviewing whether we need our sugar tax. So maybe the kind of neoliberal approach will be, we may be at a turning point here in this country too, even though our new prime minister is of the same Conservative Party for the last 12 years, we might be on a different trajectory there as well. Yeah. There is a fascinating question from Dermot that's coming. Are we a society that ignores evidence when constructing policy, or is there another explanation? What's, I suppose this is kind of the bigger, broader question, really, John. What's the, why are we seeing this, despite the evidence that you've presented, very, very strong evidence that it's been slipping? Why is it that it's been moving in the, let's say, wrong direction?
Well, so we still have a robust, vibrant, active scientific community across the spectrum of knowledge and very much across the healthcare space and the public health space. We have a huge public health community in the United States that is very, very focused on all of these things appropriately and does great work. But in a societal perspective, large portions of the American public have, and clearly beyond the borders of the United States, and who knows where it started or whatever, but we're a big part of it, simply don't trust science and believe what they want to believe, and increasingly get news through their own ideological silos. So there are fewer and fewer shared common grounds, and so in the United States we have deregulated substantially since 2010 the ability of corporations to give money almost directly to political campaigns in a way that just, I think, leaves other people around the world just appropriately shocked and dismayed that our political system is deteriorated in that way. And so there's much more of an environment where a lot of people who are delivering the messages are following the money. And I think that the role of money in politics, in public life, is becoming much more dangerous. We just had an example this past week, the day after Trump's inauguration in 2017, we had the largest demonstration in US history, the Women's March across the country against Trump on his first full day in office. And it was in DC, it was in every one of the 50 states and hundreds of locations. And shortly after the big day, the Women's March, which had intended to try to maintain momentum and hold on, fell apart. And what just came out about a week ago in the New York Times is that Russian bots, Russian infiltrators were assuming roles of participants in the action who were deliberately working to create division and to tear it apart. And it was actually successful. And within about a month or two, there was the organization just splintered and said, we give up, we're out of business, good luck, find another place to be active because it ain't going to be through us. So we see that, and we know that that corporate actors can do that, and just the examples are just overflowing. That's just kind of one of many examples of what we see in society that makes it a lot more difficult to trust in the wisdom of the crowds and the public sentiments as they were expressed, because there's so many sophisticated ways to try to undermine them and do damage.
I've always thought that the brake on your rising costs, your rising overall costs, it's pushing 20% or just under, is such a green light, such an incentive to any business to get in on the act, to get in on that rising. If it's we say the rising tide, well, everyone's wanting a piece of that cake, aren't they? So yeah, whether it's IT firms, pharma, obviously the ones we might think of, but yeah, private equity as well. It's a growth area at a time when we've had the financial crash of the late 2000s. It's a rich market to exploit, I suppose, as well.
So we look at our system in the United States, and we see fracture, we see divides, we see little colonies, we see all kinds of inefficiencies, inequities up and down the system. And it's fascinating, private, and where other people look at this and they kind of, they wring their hands, they're concerned. Private equity looks at that and says, wow, what a great opportunity.
Yeah, exactly.
What a great opportunity to get in there and take advantage of the inefficiencies to make a lot of money for ourselves. And that's really, money has always been central to US medical care, and I assume everywhere. I mean, physicians were solo practitioners, hospitals had to, keep their doors open and balance their books and stuff. But it was always kind of a shared set of obligations to their financial stability and to the well-being of patients, and providing some degree of service. Within the private equity frame, the fundamental goal and purpose of the private equity people is to make as much money as they can, to reward their shareholders and investors. And everything about delivery of services, it's just a commodity. It is just the commodification of American medical care, not in the interest of creating a better patient experience or better health, but for the explicit purpose of enriching the owners of the private equity firms. And they are there for, on average, 5 to 7 years. They will roll up like 20 dental practices into one big organization with a fancy new name. They will squeeze operations and efficiencies. They will lather the new organization with debt, and they will be the recipients of the financial rewards of the debt. And then in 5 to 7 years, they look for the next biggest sucker to take it over, and they move on to something else, and a new crowd is in trying to squeeze it again for as much money as much value as they can. So it is, you folks refer to it, we have an economist in Lowell, Bill Lazonick, who talks about the difference between value creation and value extraction. And we have a lot of, in the United States, venture capital that invests in promising new ideas and tries to bring them to the place where they can then do an initial public offering, and venture capital backs out, and they're off to glory, and venture capital gets their rewards, but that they're in there to help create value. Private equity looks for established, relatively secure and stable organizations, buys them up, takes them over, and squeezes all the value out of them, and then throws them off to the next people to take it over. And it's just very, very different. And that's why I think it's so invasive, and why I reluctantly use the metaphor of termites to talk about these folks, because that's what they are. They're eating the house of healthcare.
I should give a quick shout out to some work that my colleague Paula Hyde is doing at the Birmingham Business School on private equity in health and social care as well. So I'm afraid many of the trends that you're talking about there, John, are already happening in the UK. We've probably got the mega question really to finish in the last 10 minutes. So I'm going to combine Jake's question with James's question. So Jake talks about where else should we look at? Where should we learn from? The UK has often looked to the US for health policy ideas. That's a number of reasons for that. But also, and this is James's point about how can we develop an alternative frame if it's maybe it is somewhere else that we look for, but how can we create a different intellectual argument, not just against neoliberalism, but for something else, for public goods. And he suggests maybe around, well, Mark Moore from Harvard originally, about public value.
Yeah.
What alternative frames should we be considering? What should we be discussing, debating, researching?
Well, I think, Mark Moore developed his public value framework, the strategic triangle, in reaction to new public management over here in the United States. And particularly, he was at the Kennedy School at Harvard. And he saw the invasion of new public management, which basically said that, we value government the same way we value the private sector, return on equity. And that's it. So what's the financial return? And if there is none, then get rid of it and stop doing it. And so Mark Moore says, no, there's something more to public value than just dollars and cents. He used the metaphor of the public library, which is not a big profit center, but it serves a really important role in communities. So part of it is thinking about that respect for other purposes and values other than just dollars and cents and pounds and whatever. And that's important. But then it's also, and it's not going back to the fences and guardrails of the 1930s or 40s or 50s. But it is really trying to modernize and create a new sense of boundaries for society that reflect the needs and imperatives of the time, of the era in which we're in. So, you can't use traditional guardrails to guard against private equity because they can skate over, under, and around them. So it does take a smarter set of reactions to try to do that. And we are I'd look at a foundation in the United States called the Hewlett Foundation, HEWLETT. And in 2018, they started a new intellectual effort, initiative in the United States that they labeled Beyond Neoliberalism. So they are actually funding and seeding across the United States new enterprises across all societal domains. Healthcare is actually only a small part of what they're looking at, to really try to reimagine what is the alternative to the neoliberal regime that we've been living with for these past 4.5 decades or so.
Wow. I'm not too sure we've quite got to that stage in the UK. There are some voices that do explore that, but is that a drop in the ocean? I don't want to be too pessimistic. I don't want to end our seminar with too much pessimism, but I probably don't see, I think the forces that are advancing the neoliberal agenda are much stronger. And maybe because they're more broad, more diverse, more financially powerful. But picking up on what I was saying earlier, the way in which a lot of the public workers, the officials, executives, managers have become inculcated with that, so that they think that the only answer is to become more commercial. And of course, that's the irony. To maintain public services, we need to become more commercial. Well, I'm not too sure that's the answer either. So we've become sort of normalized into thinking along these lines, and it may well take another 40 years to shift our thinking out of that. So,
well, it
so
could,
maybe we're talking, and that's what I liked about your presentation, that taking the long view really helps in this.
Yeah, and it's Hayek and Friedman, they started their work in the late 1940s. And they, with a small tribe of others, were in the wilderness for quite a while, were laughed at, scorned, dismissed. And they didn't give up, and they understood the importance. So Milton Friedman was very, very clear, and Hayek as well, saying, look, I'm not trying to convince people today who are holding public office. I'm trying to win the next generations that are coming along, who really, because your real ideas that you're most likely to hold on to are formed at the university level. That's when you kind of do your experience, you try different shoes on to see which fits, and you go with them. But so it is a longer term enterprise, but that doesn't mean that there aren't gains that could be made in the short term. So we are seeing, for example, on monopoly and antitrust in the United States, a sea change in the past 2 years. So much so that the head of our Chamber of Commerce in the United States officially has declared war on our Federal Trade Commission. I think I already mentioned that. Sorry, I don't want to repeat myself. But so there's nothing that tells you how effective you're being than the attitudes to you of your opponents. And there's no doubt that that right now on antitrust, we're seeing a sea change. We'll see how far it goes. It could get the plug pulled from it and be dismantled tomorrow. But President Biden at this point knows exactly what he's doing and is firmly committed to this.
The clock is just ticking up towards 4 o'clock in the UK and 11 o'clock in Boston. So, John, we're going to have to pull the plug on this fascinating discussion. But thank you so much for your presentation, for your insights, and really taking that, inviting us to take that longer perspective, and giving us such a great insight into the US and potentially what's coming our way in the UK. We've got the signs of it, and maybe it doesn't look too good, but you've given us some inspiration as well as to where to take it.
So last thing, 5 words: watch out for private equity.
Okay.
That's the take-up. That's what you remember from this talk. That's 5 words. Thank you for this opportunity. It's been a real honor and pleasure to spend time with you all and to get your
thank
take.
you to John, and thank you to all of you for joining. We've had a great turnout. We'll be coming again shortly with another seminar next month, and so keep looking out on Twitter and our website for that. I think Martin will be circulating details of that, and we'll post this presentation in due course on our website. So thanks again to John, and thanks again to everyone. And we'll stop there. Thank you very much.
Thanks, everybody.